I'm Antoni Chan, consultant rheumatologist from London, United Kingdom, and I'm here at EULAR 2023 in Milan, and I'm reporting for Room Now. It's a great pleasure at this meeting to have Professor Vincenzo Venerito from the University of Bari in Italy, and he's on home ground today, and we are going to discuss with him some very interesting findings that he has presented in the meeting today in the area of rheumatoid arthritis and interstitial lung disease. We have heard a lot about artificial intelligence at the EULAR 2023 in the use of artificial intelligence to help detect not only the diagnosis, but also the long-term prognosis. And one of the things that have come up today is the whole idea of radiomics in the field of rheumatoid arthritis. So I'd like to welcome Vincenzo to come and tell us a little bit about radiomics, firstly, for our audience, and then secondly, about your study, which is oral presentation 127.
Thank you, Antoni, for your kind invitation. Radiomics is fairly new in rheumatology. It's a technology that we borrow from our cousin, the oncologist. And this technique allows us for extracting a massive number of features from DICOM images of CTs of MRI that we can harness for diagnostic and prognostic purposes. In general, you have to consider that the HRCT uses ionizing radiation, and ionizing radiation is a medium impacting a tissue. This interaction provides a plethora of parameters, the so-called radiomic features, that can be harnessed for predictive modeling if we segment a region in an organ parenchyma or the whole lung, as in our case. Actually, our study was to investigate whether radiomics feature can predict the mortality of patient with RALD. So we applied whole lung radiomics, segmenting the whole lungs with also upper airway, extracting about 121 features, and this number is standardized by the IBSI initiative. Then after some autocorrelation check, we retained a model with 4 predictor and 1 confounder. The radiomic feature that we selected, the interpretation is quite complex, but the first one is what we perceive as grayscale. The other 3 are function of the lung shape in a 3-dimensional space. And we noticed that our model had a good goodness of fit. Excuse me for the repetition. And of course, this we may state that radiomic is feasible and that a lot of potential for predicting mortality in a patient with RALD. And who knows, possibly integrating also pulmonary function test or clinimetrics, HRCT may be elevated to a source of digital biomarker, or ultimately to a possible digital biopsy.
So I think that is one of the key things with all these new technologies like AI is the importance of standardization. So you have clearly shown that you've done a lot of work to try to standardize, to allow for comparisons. There's comparisons across machines and across different images. Once you've done that work, so tell us about your results from your study that you presented today. How did it impact the prediction of mortality, for example?
Okay, in general, our cohort was included about 30 patients with RALD, and with no surprise, there were a lot of seropositive and elderly patients. The median follow-up was about 38 months. and unfortunately, death occurred in more than 43% of patients. So a very huge part of our core. And in this term, we use it a Kaplan-Meier estimator for showing the survival function of this patient. Then we use the lasso implementation of the Cox survival analysis. This particular algorithm allowed us for the selection of predictors that comes with full explainability, because they all have an odds ratio that is actually quite explainable. We all of us can interpret that. Again, the problem is the physical meaning, the meaning in physics, but of that radiomics. Of that radiomic feature that I already that I tried to explain before. Again, grayscale and the shape of the lung in a three-dimensional space.
So that's very interesting, because I think there were some also negative predictive factors, things that would predict mortality and things that will protect against mortality. So do you think this may perhaps in the future be featured in a scoring system, or a scoring score that we could use to predict outcome?
Yes, of course. We first need an external validation for this for our model. One of my aim is to also include other relevant data in a patient with ARLD, such as PFTs, kinematrics. Actually, in this step, we focused on predicting our outcome relying only on radiomic feature, the same as calcium score in coronary HRCT, which allow for a number, a measure that can be adjusted based on patient characteristics. But I think that the future is bright for radiomics in rheumatologies. We have to perform further studies on radiomics, performing more complex predictive modeling.
Excellent. That is really exciting. Clearly, the long-term aim is perhaps reducing the need to do invasive lung biopsy in some of these patients who can be quite invasive. We looked at your distribution of your patients. There were quite a nice distribution across the biologics, as in they were not very rituximab heavy or any particular heavy, so it was quite well distributed. And as you say, clearly you'll be studying the idiopathic group will also be very interesting with your radiomic study, especially with the new antifibrotic medication that is coming on now, both for idiopathic and also for connective tissue disease related fibrosis.
Absolutely, I agree with you. One of the facts of radiomics is that we can harness the information embedded in radiomic feature for any outcome, diagnostic, prognostic. So trying to predict progression, for example, or the response to antifibrotic agent is, of course, very intriguing perspective.
We look forward to hearing more about this. We live in an omics world. There's metabolomics, proteomics. Now we have radiomics as the next digital omic that we have. At this EULAR, we have also heard a lot about JAK inhibitors, in particular the risk with cardiovascular events and cancer. But you've also presented a poster in the field of interstitial lung disease, ILD, in the patients who receive JAK inhibition. Do you want to share with us your poster 0855, some of the results from your study?
Of course, I'm not sure if I
No,
can
just
share the screen.
just verbal, just verbal would be okay.
Okay,
Just a
okay,
verbal, yeah.
okay. Okay, we submitted this study is a multi-center retrospective study involving 5 Italian tertiary centers and analyzing 43 patients with RALD on JAK inhibitors. Of course, the prescription was made for array itself, for disease activity, for array-related disease activity, for joint affecting disease activity, and we noticed that we tried to analyze whether the evolution of the ALD would change on JAK inhibition. So practically, we applied the inbuilt criteria for progression, analyzing the CT in the 6 months before carried out 6 months before JAK inhibitors baseline, and we used also another subsequent HRCT carried out 3 months before the last follow-up visit. And actually, we found that a patient over a median follow-up of 19 months had a stable disease, either assessed with HRCT, but also with PFT. Most of the patient had a stable DLCO, a stable FBC, some very few of that improved. Unfortunately, very few also worsened. And I have to say that those who had a worsening disease were also YP patients. The distribution is quite skewed, and this is the distribution of JAK inhibitors in our court is quite skewed, and this is because of Italian policies in JAK inhibitor prescription. We had a lot of patients with baricitinib, then tofacitinib were also frequent, about 9 patients with tofacitinib and about 28 with baricitinib. The other were divided between filgotinib and upadacitinib. This is because filgotinib and upadacitinib became available in Italy only recently. And so we had more patients on baricitinib. No one of the patients were on antifibrotic. This is a good detail, an important detail to add, I think.
I think that's very reassuring from your study that the JAK inhibitors overall did not cause a worsening in the lung function. And that is quite nice, because at the EULAR here in Milan, we've also heard the studies of methotrexate not affecting interstitial lung disease as well. And sometimes it's more the disease that rather than the drug that is needs more attention and treatment. Do you think it's a class effect? All the JAKs would have a similar effects, or do you think it's too early to tell, because as you say, your study was a bit skewed depending on your prescribing policy, which country you are in?
Actually, I don't have evidence to state that the JAK selective drugs are better or worse than pan-JAKs, because my court was skewed. if I will try anyway, but it's my humble, only my humble opinion, I will trust either Panjac and just selected drugs in this subset of patient. But that's only my feeling. Of course, I did not have the statistical power to demonstrate any difference between Panjac, between tofacitinib and selected drugs like upadacitinib and filgotinib.
Sure, and sure, I'm sure we'll find more evidence as we increasingly use more JAKs in the future. And but from your study, at least it's reassuring that we can continue our patients on this treatment, but monitor their lung function or any symptoms that may suggest that there might be progression of any ILD. Vincenzo, thank you very much for your time.
Thank you much for your invitation.
Busy EULAR 2023 for you, but thank you for your time and sharing two key abstracts today, which are new information for us. So, and for those listening in, we will post the poster number, or a presentation number. So if you can go to that and look in more detail. So thank you very much. I'm Antoni Chan. I'm reporting for Room Now here in Milan at EULAR 2023. Thank you.
Thank you.